Hello, Calaveras County. The doctor's in. Welcome. I'm Mike Taylor. I'm not the doctor. He's sitting over here, and that's Dr. Randy Smart. Dr. Smart?
Hi, Mike.
How are you doing?
I'm doing great. It's great to be here. Thank you.
Good. Well, thanks for being here. Except this time we're talking about something that I know is miserable because I've talked to people who've had it. And we're talking shingles.
Yes, sir. We're going to talk about shingles.
We're going to talk about shingles. Now, I guess the first question is, what is shingles? And then, because we talked about it a little bit beforehand, we have to talk about why it's called shingles. But what on earth is shingles?
So the reason I wanted to talk about shingles is it can be a really devastating disease. It can change the rest of your life in a very negative way. And like all our programs, it's a disease that the patient can prevent, the patient can do something about if they just have the right information.
Okay.
And so you take a really bad problem and arm the patient with the right information. And what a great thing to do for our citizens in the county. Shingles is actually a viral infection.
Okay.
It is caused by the same virus that causes chickenpox.
Okay.
And so, as you know, most youngsters at some time early in life will get chickenpox and cause some misery at home. And what we know is that chickenpox virus, at the end of the chickenpox, goes into hibernation into one of the nerves or several nerves. And it stays there pretty much for the rest of the life of that patient in hibernation, sort of constrained or checked by the immune system. And so we also know that as we age, our immune systems don't work as well. And nobody really thinks about immunity. They know they have organs like livers and stomachs and brains and hearts. But your immune system is a very powerful organ. It's just not easy to visualize. And your immune system does so much good for you, and some bad. But as we age, that immune system weakens. And at a point, in many, many people, that virus will come back out, and it'll come into the nerve. When it does that, it causes a rash. It causes many things, but it causes a rash that is a blistering rash that is painful and persistent. That'll go on for weeks, months, and sometimes the rest of your life. So it's a viral infection that is the reactivation of a virus from years and years and years ago.
And it's called shingles because...
Right, very interesting. As many of the shingles rashes and presentations will come around the trunk or around the lower abdomen, and usually only on one side. We'll clarify that in a little bit, but have sort of a constricting or girdling effect. And shingles is derived from the Latin word for girdle. Because it felt like a girdle and you couldn't move as well, and you had this ugly rash on your side. So,
goodness, okay. Now, what does it only happen in older folks whose immune systems are starting to lose their steam, or is this something? Can it happen in younger people too?
So. There are risk factors for shingles. Some people are more likely to get it, some less likely to get it. And probably the strongest risk factor is age. So as we age, we're much more likely to get it. Now, teenagers can get it. Those are unusual circumstances. 20-year-olds can get it. 30, 40-year-olds can get it. But kind of the age where it really changes in most people is about 50 years old. So if you look at the chart of shingles by age, it stays relatively flat. And then at 50 years old, that thing just shoots
Just
up.
ramps right up there.
Just
huh?
shoots up. Right. So age is one of the risk factors. Interesting, trauma or injury can be a risk factor. And what we know is some of the shingles presentations will come around the face or around into the eye, into the ear. And there is a correlation with having a head injury and having that present a week or two later. We have no idea why that happens.
Wow.
Presumably the injury affects the immune system somehow. So trauma or injury is a risk factor. Other kinds of immunosuppression are a risk factor. For example, people that have organ transplants, like a heart transplant or a kidney transplant, they'll be on immunosuppressives that will make them maybe 100 times more likely to have shingles.
Oh, gosh.
100 times. And then in our arthritis patients that have rheumatoid arthritis or have lupus, we finally have these great immunosuppressive medicines we can control their disease with. And this has only really been within the last 15 years we've had access to these medicines. They're specialty medicines. And our patients who are on those medicines are more at risk.
Okay.
So a young lady with lupus on immunosuppressives, she's at risk, or with rheumatoid arthritis. And then finally, the risk factor I also wanted to include is gender. And women are more likely to get shingles than men.
Oh, okay.
So being older, being a woman, being on immunosuppressives, injuries, those are what put people at risk.
Now, does the fact that man or woman had chickenpox make them more likely to get shingles, or is that just something that seems to come along with having shingles, is that you had chickenpox as a kid?
So I could tell you a great story about this, but you have to have chickenpox to get shingles.
To get shingles, okay.
You have to have chickenpox to get shingles. Now, what's interesting, there's several things interesting about that. But one is that many people will tell you, I've never had chickenpox. Can tell you, I've never had it. I've asked my parents. And if you test those people, you can test them for antibodies and exposure. On the order of 80% of people who say they've never had them have had them.
Had them.
Yeah, but it may have been subtle. Maybe the rash wasn't as prominent. Maybe it was unrecognized. But when you look across the board, almost 90% of people have had chickenpox, including those that say they've never had chickenpox. And that is really a prerequisite. If you haven't had chickenpox, you're not going to get shingles.
Okay.
But if you haven't had chickenpox, you can get chickenpox. You're still vulnerable.
Yeah, now I was going to say, or preface this with saying I'm not asking for treatment. I'm not suggesting you diagnose me. But I waited until I was 32 to get chickenpox.
Oh, really?
I had, the flu-like symptoms, and then was getting ready to go to work and in the shower, and as I'm scrubbing my back, the spot, and I didn't break out with a lot of spots, but I had just some. And the reason I prefaced my question with, I'm not looking for a diagnosis, but does a later incidence of chickenpox do anything to shingles? I mean, am I going to be, worried about my girdle soon?
Mike, not that I know of.
Okay.
Not that I know of.
Because it shocked my doctor when I, came in not knowing, what I had going on. And he says, have you been around kids that have had chickenpox? And I said, oh, yeah, it went through my employer. His kids had chickenpox, and that must have been how I got it. But
there may be some epidemiologic data that would answer that. I've not ever looked at that question. I don't really know, but not to my knowledge.
Yeah. What do we do once we have shingles, once it's diagnosed? Or is it tricky to diagnose?
Well, let's talk about that. So what would a patient look for who is concerned that they have shingles? Now, One of my most common calls in my office is, "Doctor, I have the worst poison oak I have ever had in my life."
Oh.
And you go, "Well, it's January, not a lot of poison oak out there."
Yeah.
And they want, a prednisone shot or a cortisone pill or whatever. And so 99% of the time I say, "Let me look at it. Come on in
Yeah.
today. Let me look at it." And probably 90% of the time it is not poison oak. So shingles can look and feel like poison oak.
Okay.
And it can be a face, it can be a chest, it can be an abdomen, it can be a leg or an arm. But these blisters, what happens is at first there'll be sort of a tingling or a discomfort, maybe a headache, and then several days, even up to several weeks after that, you start to develop the blisters. And the blisters come out right along a nerve path. So it'll be right along the jaw or right along the forehead or right along the rib. And those blisters come out. That is the worst poison oak they've ever had in their life. And the blisters typically are more painful and burning than anything. And the pain can be excruciating. But there are some that they itch. And that's how they get confused about poison oak.
They're thinking it's poison oak.
Right, because they itch and there's blisters. So that's typically how it presents. The diagnosis is really made by the doctor in the office. There are tests we can do. We can do scrapings and microscopes and what's called serologies. But typically, 99% of the time, we'll look at it and say, "You have shingles."
That's shingles.
And it takes about that long. I mean, you walk into the room and within microseconds, you know what somebody has.
As soon as you hear the telltale worst poison oak I've ever had, and then...
Probably shingles.
Then okay.
Yeah. So there are cases where you can have the pain without the rash. Those are unusual, and those are tricky because without the rash, we're not so sure about what they have. So that's what usually happens, and the patient will recognize that. And what's important is if we can diagnose that early, and early is within 72 hours, within 3 days, we can treat that. Now, as they get farther out from 72 hours, the treatment just doesn't work. But early on, we can use antiviral medicines that work reasonably well. We also typically will use pain medicines because the pain is really uncomfortable. But if the patient can recognize it early, get on the phone early, I even have patients send me pictures over their cell phone. They may live in Burson or Wallace and maybe old, and I'll say, "Look, just send me a picture on the phone and I'll tell you what you have." So early recognition is important. Seeing the doc within 72 hours is important. And usually there is not a lot of testing involved. That would be unusual.
And so you start taking the antiviral medication. Is this something that you can cure, or is this something that just kind of goes back into that dormancy until your immune system takes another shot on the chin?
I lost a very big bet on that question with a patient. And the question, she had shingles. We also call it zoster. Treated it. A couple months went by and she called me and said, "It's back." And I said, "It doesn't come back." And she said, "Well, I'm telling you it's back."
It's back.
And I said, "Well, I'm telling you it doesn't come back." And we bet, and I lost the bet. So it can recur.
It can recur.
But it's not common, Mike. It recurs maybe 1 or 2% of people. That's unusual. And when it does recur, we get a little bit concerned about whether they have an immunodeficiency. Could they have HIV disease? Could they have a malignancy? Could they have something that is causing this to recur? And
kind of opening up that little door in the immune system that's allowing the shingles to continue to happen.
So when they recur, we get a little more concerned, and then we'll start thinking about testing. But the answer is it can recur, usually does not.
Usually doesn't,
Right.
unless the doctor has placed a wager.
Unless you go with your doctor. That's exactly right.
How long does the treatment take? I mean, it sounds like, I mean, is it kind of like poison oak in that it takes, a couple weeks for those rashes to sort of clear up, or?
So the bad news is it takes every bit of 30 days
Oh, goodness. Okay.
to get through shingles. And it's not unusual for it to last 4 months.
Wow. Okay. So this is something that takes hold.
So it doesn't go away overnight.
Mm-hmm.
And we should talk about complications in a minute, but with the treatment, when somebody comes in within 72 hours and you put them on the treatment, it generally makes the pain much better, and the blisters stop developing. They start to crust over, but it's not like an overnight cure. It's not like the next day they're going to the dance.
Yeah. Yeah.
And it can still take several weeks, but there's very good data that it is a shorter clinical course and a much less painful one than otherwise.
Okay.
The medicines that we use, the antiviral medicines, are not complicated. They don't have a lot of side effects. Typically not expensive,
that's good,
available
too.
in the county. So when we can, we start that treatment. And hopefully those aren't the patients that go on for months and months and months, right?
What are some of the complications? You started to talk about that, and I guess the question for me with a complication would be, is this something that, okay, we get to, say, about a month, we've been taking the medication and maybe the rash started to clear up, or when do complications that can arise kind of show up?
So they can occur relatively quickly. The simplest complication is these blisters can get infected by bacteria. So most people have heard of MRSA or strep or staph. And so if you have an open wound or a blister, that can get infected by bacteria. So that's a relatively common complication, 5-10% of people. And as long as the doctor or the patient recognize it, it's treatable antibiotics. Then there's more serious complications. The one we really worry about the most is called post-herpetic neuralgia, which is basically pain that doesn't go away.
Okay.
And so you can get shingles, let's say it's on your face, and the rash gradually crusts over and gradually goes away, but the pain never goes away.
Oh,
And the pain goes on for the rest of your life.
Wow.
And that is called post-herpetic neuralgia. It's disabling. It's very depressing for patients.
I can imagine.
And the treatments are basically treatments for pain. But people have been hospitalized for it. We've lost patients because the pain incapacitated them, ended up in bed, complications, and a year later they're gone. So the chronic pain is really a problem. And then another complication that patients should know about is you can have scarring.
Oh, I can imagine
so
that
these
too.
blisters and pocks don't always go away, and you can have scarring, and for many people that can be a big deal.
Is it kind of like what, and I may be speaking out of turn here, but again to poison oak, I'd heard that, scratching a lot on the poison oak can cause you to scar. Is that kind of the thing? If you're messing with the shingles, the sores a lot, does that cause them to scar, or can that contribute to it? Or?
I don't think so, Mike.
Okay.
I think you either have the kind of skin and the severity of the infection that you scar, or you don't.
Or you don't. Since this is from chicken pox, which is ridiculously contagious, is shingles contagious?
So great question. It was really not understood until 1965 whether it was contagious or what even caused it. And what they found is it's the recurrence or reactivation of the chicken pox. The fluid in the blisters has active virus in it.
Oh.
So the fluid, if you take off the blisters or you scrape them or they break open, that fluid doesn't cause zoster or shingles.
Shingles.
That fluid can cause chickenpox.
Oh, I'll be darned.
So let's say I have shingles, and let's say you didn't have chickenpox when you were 32, you've never had it. If you were to come into contact with the fluid in the blisters, you could have chickenpox within 10 to 14 days.
Oh, wow.
So the fluid is contagious. We recommend people put some Band-Aids or dressings on.
I was going to ask about that too. I would think that you would want some kind of topical treatment to keep your shirt from rubbing on it or whatever.
But then there's patients they should really avoid. Anybody who's pregnant is susceptible, and their fetus is susceptible.
Okay.
Anybody who is a transplant patient, they should avoid.
Yeah, because their immune system has been purposefully
they're
knocked
vulnerable.
low.
Right. Anybody who's on these other immunosuppressants related to arthritis or lupus, they should avoid those. And certainly our young little toddlers who haven't had chickenpox yet, they should probably stay away from them.
Yeah.
But it's not very transmissible.
Okay. Yeah, it sounds like you've got to come into contact with that sore, and let's be honest, as much as we'd like to help our loved ones, we probably don't want to wipe that kind of stuff
Probably
up.
not going to happen. But it's not, chickenpox is transmitted through aerosolized droplets. Very contagious, like you said, almost 100% contagious. If you go into a household and one's got it, they all get it.
Yeah, they'll all get, and that's what happened with this family. There were 3 kids, and they all had it within 2.5, 3 weeks of each other.
100%.
Yeah.
So shingles is not aerosolized,
Okay.
as far as we know, and so there isn't that respiratory transmission.
Okay. Now, also, and as much as I'm against it, it does help us learn stuff. We're seeing commercials now for some kind of a vaccination for shingles. Is that?
So we should talk about that. And that's one of the main reasons I wanted to do this show today, is shingles can be very preventable through vaccination. And I think it was around 2008, a product called Zostavax was approved by the FDA and made available to patients. It is a live virus vaccine. So the virus in Zostavax is attenuated and kind of knocked down and kind of not very active, but it's alive.
It's alive.
That's important.
Yeah.
And so the current recommendations by the CDC and many others are that anybody over 60 gets Zostavax
Okay.
when it's available. And so you can do that at almost any drugstore in Calaveras County and any other county.
Is that the, and I was going to ask this, but, you see the sign out in front of the store that, have you gotten your shingles vaccine? Is that the drug that's given? This is Zostavax?
Yes, I think, yes.
Okay. I'm just making sure that there wasn't another one that's, the new kid on the block that we're not sure of yet or something like that.
Well, interesting you would bring that up, that there in February, last month, they approved a inactivated vaccination for shingles.
Okay.
For these transplant patients and the immunosuppressed patients.
Oh, so they're getting
because
a weaker...
you can't vaccinate them with a live virus, otherwise you make them sick.
Yeah.
So that is just licensed last month. I don't know about the commercialization of it. I can't even really remember the product name, but that's going to be available. And, and actually, if the financing is right, that may be the vaccination of choice.
Are these both injections?
They are. They're
okay.
subcutaneous, under the skin injections. So Zostavax is indicated in anybody over 60. It's only given once. It doesn't work as well in 70 and 80-year-olds.
Oh, okay.
And it doesn't have forever immunity. So because people under 50 don't get a lot of this, and 60 was decided that is the right age. It doesn't cost a lot. It's paid for by insurance. Sometimes there's co-pays or deductibles, but that might be $100 to prevent a disease. And then in the patients who have immune problems, and they should only do this in consultation with their doctor.
With their doctor, yeah.
They could be vaccinated at 50.
Okay.
Rather than 60, but not everybody, and it has to be on a case-by-case basis.
Are you going to get a little slight case of shingles when you get this live virus as the vaccine?
You know, Mike, people tolerate this really well.
Okay.
They might have a day or two of malaise or just feeling a little punky.
Even sometimes you get that way after a flu shot. I know everybody
Exactly.
insists you're not going to get sick from it, but you always feel kind of dragged down the next day after you got your flu shots.
And if you compare the flu shot to influenza, piece of cake.
Yeah.
And same with shingles. If you
Okay.
compare that day or two of malaise with a live case of shingles,
Yeah.
it's not even
4
close.
months of painful. Yeah.
We were concerned that people would develop chicken pox, a localized chicken pox or shingles from the shot because it's a live virus. And we just haven't seen a lot of that.
Haven't seen that. Okay.
No, that just hasn't materialized. So it seems very safe. Not a lot of side effects or problems. Affordable, and as far as I know, I don't believe you need a prescription to get this.
Even to get the vaccine, right?
Right.
Okay.
You just need to
So
show up
you-
and say, I'm 60,
Okay.
I want the vaccine. And
So
I
if
believe
by
they
the
do.
time you've gotten on Medicare,
If you're on Medicare, you should have had it already.
you should have had it already. That's what I
But
was
if
just
you were
thinking.
uninsured and came into Medicare, then you should definitely get it. And Medicare does pay for it.
Okay.
Yeah.
So we're down to our last minute or so. So the painful poison oak when you haven't been anywhere near any poison oak is a telltale, got to call the doctor, got to get in soon.
Especially in a distribution.
Okay.
Especially in a distribution.
All of a sudden shows up in a big space and, okay,
And even more important, if it's in a face,
okay.
you can really have lifelong eye problems if you don't
Oh, goodness.
get this early.
Okay. So,
And it can go into the eyeball and into the globe. So if you have a face rash that you think is poison oak or shingles and there's any eye involvement, I really regard that as an emergency.
get to the doctor. So hopefully, ladies and gentlemen, you won't end up with shingles. But I'm going to thank Dr. Randy Smart for telling us all about it so that we know how to avoid getting shingles. And on that note, I guess I'll say the doctor is out.
Thank you, Mike.
Dr. Smart, thank you.
My pleasure.
Next time, who knows what we'll discover, Calaveras County. I'm Mike Taylor. Thanks for joining us. Be healthy.